I enjoyed the discussion of the Mauro presentation because I think we have noticed that we were talking not just about medicine, but about making choices. Who has to be in the ICU? How much should we do? When to stop? And that is the kind of questions that I have in presenting the intracranial hemorrhage. Because I think that it's quite easy to believe we have a very severe patient, he is very sick, so he comes to the ICU, which makes sense. Then we should ask ourselves, we are spending a lot of energy and resources for a patient, and the only justification shouldn't be that he was severe. The only justification is how well he will be home, so how useful our treatment could be. Otherwise, we are simply wasting resources for the more severe, rather than giving the little resources that we have. We are always short of money, and I think that also in France, for the next years, we will be even shorter of money. And so we are responsible of giving what we have to the few who could benefit of it. That's the philosophy. Then let's do something for really giving my talk. And I think that the first issue is that I am talking about something which is relatively frequent, and you see 2 million a year. And the bad news are that it's becoming not just more frequent, but is involving young people. The typical patient with intracerebral hemorrhage were the grandsons, hypertensive and old. Now we have the nephews or really the young people, and the reason is drug abuse. To have a bleeding, usually you have something wrong before, so a pathology of the vessel, and you have an hypertensive crisis. So you have this. This is a 32 years old, let's say, young man. So that is clear. If you take ecstasy or you have too much cocaine, your heart is beating a lot and your pressure goes up. But there is something worse. If you have a long story of abuse, you have a direct injury of the drugs on the vessel integrity. So you have vasculitis due, for instance, to cocaine, which explains this combination. Something pre-existing plus hypertension, then you bleed. So the face of the patient is changing. Don't be surprised if you will be called one night for a young man with, or a young girl with this kind of pathology, and please think about the possibility of drug abuse, and that is the ethical concern. That is the reason why I am a little bit skeptical in talking about it. In general, you expect very high mortality, but even worse, you expect 3 patients on 4 going home, if they go home, dependent. They will need total assistance 24 hours a day, which is really concerning. So let's make a distinction. The great majority of cases is the typical intracerebral hemorrhage, what is called primary intracerebral hemorrhage. And we do know that that is linked to a pathology of the vessel, amyloid deposition, atherosclerosis, and you have the typical histology of a wall of the vessel which is damaged. But there is something which is not so typical as this distribution. So if you are thinking at the primary, you should expect mainly in the basal ganglia or in the posterior circulation or subcortical. That is the typical appearance of this kind of pathology. There is the secondary intracerebral hemorrhage, which doesn't come from a subtle chronic pathology of the vessel, but is due to malformation or aneurysms, like Giuseppe Citterio was presenting in the first presentation. And that is extremely important. This is last Sunday, 52 years old, from Philippines. And you see here, that is the hematoma. And you see there is too much blood also in the other side. So please be always very suspicious. don't ask the young surgeon to take care of this case urgently, because there is a surprise. And the surprise is this beast, is this aneurysm on the posterior communicating artery. If you do surgery in this case and you simply target the hematoma, you will kill the patient in the OR, because the only way to stop the bleeding is to close the aneurysm. So we should be very quick, but very intelligent and careful. What happens in general? In general, we have a little bit of time, we have a patient, and we know that the hemorrhage is a cause of tissue destruction and producing hematoma. Then we will talk about hematoma expansion. Please be aware of the fact that what you see at the beginning is not what you will see in a few hours. So there is a special case which has to be taken with extreme attention, and is posterior fossa. If you have a problem about the tentorium, supratentorial, you have the whole cranial cavity available. But if something happens into the cerebellum, that is a tiny space. And you have two problems. You may have direct compression of the brainstem, and or you stop the normal flow of cerebrospinal fluid, so CSF is obstructed and you have hydrocephalus. So posterior fossa is a different issue. Then let's think about hematoma. The hematoma per se is a disaster, is the blood and is destruction, but also is something which is injurious, which is deleterious to the tissue. And there are reasons for that, and usually we were thinking at thrombin, and we should concentrate a little bit on inflammation. There is a cascade which may involve the blood-brain barrier, and I would like to suggest this paper. If you are curious about the mechanisms leading to the tissue damage, not just due to the hematoma, but to the consequences, I think this is a very good review, which says that when you have red cells coming in the tissue and disrupted with time, you have additional inflammation and you have injury. That you can see indirectly from these, I think, quite eloquent pictures. Here is what happens to the rat if you don't do anything, and this is what you have if you use deferoxamine. I am not saying that you should use deferoxamine in the patients, but I think that that is a clear demonstration that if you block one of the mechanisms involved in the inflammatory cascade, then you have a clear reduction of the tissue injury. What about edema? Of course, you have compression, you have inflammation, you have BBB opening, so you have water accumulating in the tissue. And that is what very often happens. You have hour 1, so beginning, and 5 hours later. Of course, if we have to take a decision under this CT appearance or at this point, I think that we all will be quite distressed and our views could change. So hematoma expansion leading to, together with edema to a mass effect and to raised ICP and possibly reduction of flow is the issue that we have to deal with. So the surgeons started thinking about that. I think this is a very nice study, 2002. What they did SPECT in this situation, then they did surgery, so they removed the hematoma and they repeated the SPECT, looking for flow. And in red, here, you see the gain, the advantage, is the subtraction of the two SPECTs, proving that by doing surgery, there was much more flow. So surgery was effective in restoring a little bit of flow. And that is, I think, is the basic premise to do surgery. The surgeon view could be quite easy. We have a clot, we better take it out. Remove the clot. But the surgeons today are quite smart. David Mendelow ran a study. The name is STICK. And that was a randomized study starting with a lot of patients, but we don't know how many, and leading to the randomization of more than 1,000 cases. And the idea was, when the surgeons in several centers across Europe were uncertain if do or not to do surgery, they randomized. And these are the results. Approximately half and half of patients, with a few exceptions, and these are the final results. So you see here the probability of survival. No differences at all. That is a surgical trial, with the surgeons asking themselves if surgery made sense. It didn't. And by looking at the figures, I anticipated this point. Unfavorable, 74%, 76%. So exactly the same, but again, 3 patients on 4 doing very badly. And these were the conclusions. I think very brave. They were really very honest in saying surgery here was deleterious, increased the probability of poor outcome. So I think it was a very important trial, and these are the different subgroups, and they focused on the only situation in which it appeared that surgery could be useful. Surgery didn't help. There was no difference. But there was a subgroup, and it was a group with a clot very close to the surface of the brain, very superficial. It appeared that in those patients, surgery made sense. And if you think about it, because you can reach the hematoma without cutting too much brain, and it could be easy to remove it. And that is stage 2. So they, again, randomized patients to answer the question, if we restrict surgery to these candidates with superficial clots, are we gaining something? So they did this study, and you see 300 cases, so quite a big number, no differences. You can say that the blue is a little bit below the red, but there are no statistically significant differences. So it was, again, a failure. And the failure, now we can just spend 30 seconds concentrating here. The failure is, this is the scale which is used to rank the outcome of patients later after this acute phase. And you may say that these patients, these 2 colors, are the good one because they recovered, more or less. If you are very benevolent, you can also say that these pale blue patients do well. They have disability, but they can still live by themselves. They don't need continuous assistance. But please concentrate. This is 100%. And that is the proportion of cases that we may believe did have a favorable outcome. So it's really something still very sad. Hematoma expansion cannot be usefully impeded by surgery because surgery didn't work. But we can do something. Why don't reduce the expansion of the hematoma? I think that that is another possibility. If you look here and you see here the volume increase and unfavorable outcome, there is a proportion. The bigger the increase, the worse the patient do. That is, I think, a very rational reason to think about stopping hematoma expansion. How to do that? For instance, by improving coagulation. And that was the story of factor 7. It was a big endeavor. The idea was very good, but they selected good patients because they were not the very severe. They were patients that could be randomized in 3 hours, having the bleeding, and they were submitted either to placebo or to 3 different doses of factor 7. And the idea was, at the end of the first day, we will check again the CT scan looking for the expansion. Is factor 7 capable of keeping the clot stable and not enlarging any further? Yes. If you look at the figures as they have been published, it looks like that there is a volume that includes the blood into the intraventricular, into the lateral ventricles, and that the total volume, including edema, and you see that you have a % reduction, which is a little bit significant if you use factor 7. But be always very skeptical about the advertising. When we write a paper, we want to say something good. But if you look on this axis, how much the reduction has been achieved? 8%, 6%, 10%. Meaning that if you have 100, you have a maximal gain of 10. It's nothing. And that is reflected in the outcome. No gain. There was no benefit. What about lowering arterial pressure, which is the driving force? So if you have pressure, you may have enlargement of the hematoma. And I would like to show you two trials. That is the first one published last year. And the idea was not big numbers, 75 patients randomized in two groups with rapid lowering. Neurologists trying to be like intensive care people or like surgeons, so quite aggressive and quick. And they injected something to lower the arterial pressure. And they did. There were two groups, and starting around 180, they were quite effective in keeping, you see the red group, the pressure, the systolic, below 150. And they said, okay, look at flow. Here you have patients managed with the aggressive treatment. Here you have patients not managed very aggressively, so the old way. And looking at flow, there were no differences in flow between the two groups. These are just examples. Again, be skeptical. That is my way of looking at these data. I don't care if there was no further reduction. Please look at this difference from the injured side to the other. Highly statistically significant difference. We are talking about patients who do have a reduction in flow. Therefore, the idea of lowering the driving pressure is still scary. We can conclude that it didn't add further injury, but we can't say that it was beneficial. This year, New England, big study, not 75, 900 patients. So much more convincing. And in this study, again, no benefits. So I am really uneasy, uncomfortable in showing you how often we failed and we have no options at the moment. Because that is the summary, at least in my mind. And what I can understand at the moment is that we start with hemorrhage, we have destruction, we have the hematoma, which may expand, we have further damage, we have a mass effect, we have ICP, perhaps we have problems with flow, and in all these directions, we don't have really the possibility of proving efficacy. My personal view is that it's very sad, it's very really depressing, but probably we are looking at the wrong side of it. Because the first question is, why the patient is bleeding? We have the exception of the young man sniffing cocaine all the day. That is a different situation. But in general, why this patient did bleed? And the reason is that we have to think about additional causes that I show here. The candidate for the typical intracranial hemorrhage is a patient who had a chronic history of arterial hypertension and vasculopathy. If you look at the brain of the patient who suffered the intracerebral hemorrhage, it's not a normal one. It proves chronic flow delivery inadequacy. They very often have previous signs of ischemic damage in the preceding months and years. Therefore, perhaps that we are looking at the very end stage of something, and we try to revert it when it's too late. So perhaps really that we are trying to rescue the wrong patient under these conditions. And since I have still 1 minute, I would like to show you